the 33 million, 2.1 million are dying. And this is despite the presence of antiretroviral drugs that would keep a person healthy and alive and well. But there are issues and then breaks that we will discuss in somewhere one of the next lectures. But to know that 2.5 million infections occur every year and about 2 million, 2.1 million people dying, these are estimates. Of course, these are not the real head counts, but they are more or less closer to reality. It's important to know that despite the amount of knowledge and amount of things that we are talking about, we still have this epidemic that is dynamic. It's moving. An example that happened in the country that always boasts of the best public health is the United States has got a root shock this year, last year, 2008, that in the whole of United States, because of the massive information and massive literacy rates of that country, the new infections in the U.S. had fallen to about 29,000 cases in the whole year in the entire 300 million population of the United States. But in 2008, they realized that because they had kind of gone complacent, they thought that everything was happening, only 30,000 new infections a year. In 2008, they got a head count of new infections occurring as 55,000, which means there is about 90% increase in new occurrence of new cases or new infections in the U.S. Now, this slide that is now on your vision is just trying to show you a curve from 1990 to 2007, how the 33 million people have eventually kind of accumulated. But I have added a small line at the back, on the bottom of it, and says that in 1986, WHO in Geneva convened the first meeting on HIV. Fortunately, I was part of that. And we first estimated a global number of infections of HIV as being 10,000. There was an estimation in 1986 that there are 10,000 people who are infected with HIV globally. And that was, of course, because very, very little was known, and whatever was known was the estimate based on that. But something that could have been contained, if it was that easy, that a sexual epidemic can be contained, then we wouldn't have been looking at 33 million infected people. Now, with almost now 2.1 million dying almost every year. So that's a very large number. In Asia, our own subcontinent or a group of countries in Asia, the number of infections at the moment is about 4 million. So out of 33 million, the Asian region has 4 million people living with HIV and AIDS at this point. Predominantly then, where is the most of the infection? I think some of these slides are saying almost the same thing, so we will just move on. And these are again talking of deaths. We just talked about 2 million deaths a year. I think this figure will remain with you for a while. But if there are only 4 million people with HIV-AIDS in Asia, the real bulk is in sub-Saharan Africa. We are not talking of whole of Africa. There is a Sahara Desert that goes across the heart of Africa, and amongst the 54 countries of Africa, half of them are below the Sahara belt, and that's where you have 22.5, almost like 85% of the load of HIV/AIDS is in sub-Saharan Africa. There was a point in time 10 years ago that countries like Botswana and South Africa, Botswana, Lesotho, and South Africa, the prevalence of HIV reached 35% amongst adults, which means that 1 out of every 3 people sitting anywhere were HIV infected. And that of course has kind of receded a little bit, not because it's not curable, so couldn't have been cured anyway. The question is, it receded because a lot of infected people actually died because the antiretroviral drugs were not available and not actually discovered by then, and now that people are able to live longer, at the same time the newer infections have declined, but the adult prevalence in sub-Saharan Africa across the board is now at 5%, and while in South and Southeast Asia it's 0.3%. I know Indonesia is at 0.2% of the adult population. East Asia is at 0.1, so that's where Philippines is. Been very fortunate all along, despite the number of sex workers in Manila. And Eastern Europe and Central Asia is 0.9. India is at 0.9% too. A big country, 1.1 billion people with 0.9% of seroprevalence. Good. I think you will remember some of those figures. I have not shown you Americas and Latin America because that would kind of add up more of zeros in our minds, so we don't want to forget the messages. But there are models how the sexual transmission has been kind of contained in sex workers in Kenya, and this model actually drove the world's major interventions. We will touch this in one of the next lectures, but I just wanted to make a point, and the point is that when we talk about cofactors like sexually transmitted infections, or we talk about barrier preventive measures like condoms, these, if they are done individually, they do not work as well, and this is where you have an example, that if there are no interventions, the female sex workers in Nairobi, city of Kenya, from 1996 to 2004, the prevalence went up amongst the sex workers from 10% to 62%. But if you were going to apply intervention where condom alone was to be used, then would have been, first of all, is the brown line here, that if there was only STI treatment, then the prevalence would have stabilized around 40%. But if there was only condom use and no STI treatment for the ulcerative and discharges, then would have been around 38%. But if you treated their genitals and gave them good genital health, at the same time they use condom, most of their sexual intercourse, then this prevalence over 8 years would have gone to about 24%. So we are talking of combination factors, and that's the point I wanted to make here, that let's not say that, okay, if the population starts using condom at every sex, there will be no HIV transmission. It doesn't happen like this. A quick look up at what's happened in Mumbai, and this is 1990. Very early in Mumbai being a city with 14 million people living in a small peninsula, and it's showing you some red spots where the main HIV concentration was. These were the main hospitals in Mumbai, very large government hospitals where most of AIDS was being reported in 1990. And our US program started to follow this up as a collaborative program with the government. And in 94, 96, the concentration of HIV was spread very rapidly. So in 4 years, you can see the infection traveling out from the concentration zones, which were also the sex worker areas that I showed in the slide earlier, to all the suburbs, which are generally the residential areas, which you see in blue and yellow. But what you see in red here in Mumbai is the industrial zone. So a lot of infection moved from the sex worker areas to the industrial subzones in 4 years. And another 6 years, the yellow spots disappeared, the red ones are gone, and what remains is very high level of concentration across a metropolis or a megapolis. And what it probably means is that while the efforts were being done to contain the sex worker areas in Mumbai, the level of knowledge in all the suburbs and the general population was not enough, or the knowledge was there, but it was not being applied as part of safer sex. So the infection spread out so rapidly in 7 or 8 years that now it's all that you're dealing with is a very high level of seroprevalence and infection in a city, which is supposed to be an economic hub of India. So then there are certain sexual practices which are population specific, and that would talk about various type of sexual practices which normally do not come to surface, and one which came to surface during one of our studies in Africa was dry sex, and it's very common in countries like Malawi and Kenya and Zambia and Zimbabwe, where women would wipe off the secretions during sexual activity, and so that there is more dry sex and the man has more sexual pleasure. But in the process there is a lot of abrasion, and any infection or STIs, they transmit very rapidly. Similarly, there are more pebble sex that we know of in certain parts of Pakistan and Nepal, and herbal desiccations are more common in certain parts of China and India, where women will have a herbal douche which will cause desiccation of vagina, and this will lead to more of a dry sex. So there are several sexual practices, and these of course have come out as a result of HIV epidemic because people have been looking at it. But we have to pay attention to this, and the part of intervention to dry sex later on came out to be was that there are now posters printed in several parts of Africa where it's saying that it is great to have wet sex, great to have lubricated sex, so that people discontinue this type of high sexual practice. And now, of course, another factor is the antiretroviral treatment, which is increasing excess of antiretroviral. Now there are almost like 3 million people across the globe on antiretroviral treatment. Now, when we say there are 33 million infected people living with AIDS, HIV and AIDS, only 3 million people are on ART. Obviously, there are not all the 33 million who deserve to be on ART at this point, but then the needs are that there are about 5 or 6 million people who would desperately be requiring antiretroviral treatment, and they are not getting it. But those people who are getting antiretroviral treatment, their virus gets under control, the viral load is low, and as a result, biologically, they would be transmitting less to people during sexual intercourse. But also behaviorally, they have been counseled, so they will be going for a safer sex. So there are lots and lots of these issues, but one of the quick slides, which of course again I think we'll discuss next week, but want to make sure that Cambodian success story is not lost, and that Cambodian success story is that most of the brothel-based sex work in Cambodia is now using condom all the time in 96% of the clients. And when this condom is being used so excessively in a concentrated area, the prevalence, the general HIV prevalence from 1997 to 2007 has fallen from 3.6% to 0.8%. Now, this type of success story hasn't been heard before, but certainly to say that, yes, in a small country like Cambodia, it's possible to do that. And when you are able to do all that, it's the use of this latex. There is a female condom that I'm sure probably most of you have seen it. If you haven't, then these are now also very easily distributable through the national programs. The male condoms are being used in millions in several parts. However, the epidemic just kind of gets sometimes out of hand, and this is the epidemic, just the last few slides, the epidemic in Indonesia, where the total estimated number of people infected in Indonesia amongst 240 million people is 270,000 people. That's more like 0.2% of adult population of Indonesia is infected. However, the epidemic in each country is different. So what you see here in terms of Papua, for example, has 2.1% prevalence amongst adults, while most of the other areas are okay, they are probably low, but there are certain areas which have a very high level of infection. And then countries would normally map the high-risk groups. So here we are probably looking at, in Indonesia, almost like 3 million adults who are clients to sex workers, so they have multiple sexual partners. There are 93,000 people estimated to be ID users. There are 220,000 women in Indonesia who are sex workers. Sorry, the IDU number is 219,000, and the partners of the IDUs is 93,000. And so, like 766,000 men are estimated to be having sex with men. So we have these mapped numbers, which are, of course, not mapped. These are estimated numbers where more attention could be paid to individuals who are at very high risk of transmission. So I think what I've tried to do is made some points, and I've also tried to show you how the epidemic goes on with transmission trail. More or less, it's IDU and sex worker-driven, multiple sexual partners. And obviously, in the next lectures, I think you will have more of interventions being discussed and how efficiencies of these interventions work. So I think I will just wind up my lecture here and let Rita conduct the question and answers, and we'll be glad to answer any questions. Thank you.
Yeah, thank you very much for the interesting presentation, Prof. Subhash. And then now I will invite the University of Diponegoro, because last time you cannot ask question, right? So please, Diponegoro. So yeah, I think because we have a very limited time, so one question.
Okay, thank you very much. We are from Diponegoro University, Semarang. I would like to ask about perinatal transmission, especially from mother to child transmissions. As we may know that the possibility of transmissions from mother to child, I mean through breast milk, is showing only less, very low possibility. So my question is, what if an infected mother and she's delivering her baby, which one she should take? First, give the breast milk to her child or not? Because I've read from some book or reference that the colostrum itself is also help the baby to prevent from HIV infection. Thank you very much.
Wow, it's a very good question. You're talking about high concentration of virus in the colostrum. The colostrum is the secretion that occurs in a mother who has just delivered for the first 3 days, and very high in antibodies, but at the same time very high in virus. What is recommended is that breastfeeding and breast milk is good for baby. Overall growth of baby, overall psychosocial development of baby, and breast milk must continue as a global recommendation. However, those who can afford to avoid breastfeeding in terms of where the mom is infected, then top feeding should be considered. But however, most of the developing world is unable to look at the economics of top feeding. So breastfeeding is definitely recommended for the first 6 months. So we are talking about avoid the colostrum for 3 days, and then continue breastfeeding for 6 months, and then take the baby over to the semi-solids and top milk. So that is one way of reducing the breast milk transmission from an infected mother.
Okay, thank you. Next is University of Erlangga. Erlangga, are you there?
Okay, thank you. From Erlangga University, I want to know about variability of sperm that's consists semen. People living with